Welcome. Okay, so when a patient has a heart attack or an MI, that medication list can get really complicated, and it happens fast. In this explainer, we're going to cut right through all the noise and focus on the absolute most critical, evidence-based pearls that you, as a clinical pharmacist, need to know to make a real difference. All right, so here's our game plan. We're going to kick things off with a super powerful statistic, then we'll break down the core drug classes you'll be managing. After that, we'll tackle a really common and tricky anticoagulation puzzle, and we'll wrap it all up with some essential patient counseling pearls. Let's jump in.
Let's start with the one number I want you to remember from all of this: 75%. That's the approximate risk reduction for death, another heart attack, or a stroke that we can get when a patient just sticks to 4 core medications. I mean, that's a staggering figure, and it just goes to show how absolutely critical our role in medication adherence really is.
And this table right here, this shows you exactly how we get to that 75%. You start with an 8% event rate, and then just look how each drug class we add just chips away at that risk. It's not about one single magic bullet, it's about the powerful cumulative effect of stacking these therapies. This is the why behind what we're going to call the Fab Four.
Okay, so let's start building that foundation. Pillar number 1 is preventing another clot, and that means you have to master dual antiplatelet therapy, or DAPT. After a heart attack, and especially after a stent is placed during a PCI, DAPT is completely non-negotiable. It's what keeps that brand new stent from clotting off.
Now, when it comes to choosing that second antiplatelet, the P2Y12 inhibitor, the details really matter. Prasugrel and ticagrelor are definitely more potent, and they're generally our first choice, but they have some major caveats, right? Prasugrel is a hard no-go in anyone with a prior stroke or TIA, and you got to be cautious in patients over 75 or who weigh less than 60 kilos. With ticagrelor, you absolutely have to counsel on that weird side effect of shortness of breath or dyspnea, which hits about 1 in 7 patients. And then there's clopidogrel. You know, it's less potent, but it has a super important niche as the go-to agent when your patient also needs to be on warfarin. Okay, so beyond the antiplatelets, our next 3 pillars are all about long-term heart protection. We're talking beta blockers, ROS inhibitors, and statins. And for these 3, the mantra is simple: titrate to target. It's not enough to just have them on the list.
With beta blockers, dose titration is everything. We get them started early to prevent another infarction and to stop arrhythmias. But the goal, the real target, is a resting heart rate under 70 beats per minute. That's how we lower the stress on the heart. And remember, if the patient has any LV dysfunction, this is lifelong therapy. So we're pushing for those target doses of the proven agents like metoprolol succinate, carvedilol, or bisoprolol.
Next up, RAS inhibition. So an ACE inhibitor is good for pretty much all post-MI patients, but it's absolutely essential for anyone with a left ventricular ejection fraction under 40%. It's key for preventing that harmful remodeling of the heart muscle. Just make sure you counsel on that classic ACE inhibitor cough. If it happens, no big deal. Switching to an ARB is the easy, evidence-based fix.
Now here is a critical safety check for us as pharmacists: potassium monitoring. Anytime you're using an ACE inhibitor or an ARB, you've got to keep an eye on potassium. But especially if you add a mineral corticoid receptor antagonist like spironolactone or eplerenone. For those patients with significant heart failure, that risk of hyperkalemia really shoots up. We have to make sure potassium is checked within a few days of starting or changing the dose and then monitored regularly.
And the final piece of our foundational puzzle, the statin. You know, having a heart attack is basically an automatic ticket to high-intensity statin therapy. This isn't just about cranking down the LDL number. It's about stabilizing the plaque in the arteries to prevent future ruptures. That means we are aiming for atorvastatin 80 or rosuvastatin 40, and we're shooting for an LDL way down below 1.8 millimoles per liter.
All right, now for what is maybe one of the most complex scenarios we face as pharmacists: the anticoagulation puzzle. This is when your patient needs antiplatelets for their shiny new stent, but they also need an oral anticoagulant for something else, like atrial fibrillation. This is a real balancing act between preventing clots and causing a major bleed.
I mean, this is such a common and high-stakes question, and it's where we can really step in and make sure things are done safely. The patient has 2 big risks, right? They could have a stroke from their AFib, or they could get a clot in their stent. So how do we thread that needle? What's the right call? Well, the evidence has just dramatically shifted our practice here. We've totally moved away from the old triple therapy, that's aspirin, a P2Y12 inhibitor, and warfarin, because it just caused way too many major bleeds. The modern approach is what we call a dual pathway. That's typically a DOAC plus a P2Y12 inhibitor, and that inhibitor is usually clopidogrel.
And here's the most important change. We stop the aspirin really early, often as soon as 1 day after the procedure, to slash that bleeding risk.
The Augustus trial was a huge, landmark study that really cemented this change in practice. It gave us the clear evidence we needed. For patients on a DOAC and a P2Y12 inhibitor, dropping the aspirin leads to way less bleeding without losing effectiveness. It is, simply put, a safer strategy.
So, now for what I think is the most important part. How do we take all of this complex pharmacology and boil it down into simple, actionable advice for our patients? Because empowering them is absolutely the key to making sure they stick with it and stay safe. Here are 5 high-yield points for your next patient counseling session. First, frame their core meds as the Fab 4 and hit them with that incredible 75% risk reduction number. Second, warn them to avoid NSAIDs, especially ibuprofen. Third, tell them exactly what to watch for with bleeding and to report it immediately. Fourth, this is an easy one. Remind them to get their annual flu shot. It actually protects their heart. And fifth, and this is so important, don't forget to ask about their mood. Depression after a heart attack is incredibly common and it's treatable.
So I'll leave you with this question. We have these amazing medications that can literally cut the risk of another event by 75%. Our great challenge, our mission as pharmacists, is closing the gap between just writing the prescription and actually achieving perfect adherence. How can we use our expertise, our tools, and new technology to make sure every single patient gets that full, life-saving benefit? That's the goal.